Hello there, I'm Kristen Omert. Jennifer and I created this presentation for you to hopefully help give you a little more insight into what we do within the NICU setting and further discuss feeding. Although Jennifer and I are two different disciplines, she's speech therapy and I'm occupational therapy, in the NICU we act as the same service and serve as neonatal therapists. So we share the same caseload, we share the same goals and plan of care. And that's typically why you won't see us on the same day, because we're really trying to make sure these babies get coverage throughout the week. Our neonatal therapy role is that we provide specialized, individualized interventions to premature and medically complex infants, aiming to optimize their development, prevent developmental delays, and support the infant-family bond through assessments, therapeutic activities, and education for both the baby and their caregivers, all while considering the unique medical needs of the NICU environment. Our services should always be integrated, neuroprotective, infant-driven, and family-centered. This is what we're protecting. As you can see, there is rapid neural pathway growth during the time that we have these infants in our NICU, especially our little 32-weekers. Their overall brain size and increase in cortical folding is significant. At 34 weeks, the brain has obtained 50% of term cortical volume. All of the wrinkles, ridges, and grooves are through the multisensory experiences these infants receive. It is based on what they feel, how they perceive where their body is in space, through movement and balance opportunities, smell, taste, and what they hear and see. Not only is there so much maturation of the brain from 24 weeks to term, but these are images of a brain from year 1 to 6 years of age. Although the main goal in the NICU is to medically treat these infants and to get them home to their families as quickly and as safely as possible, within our profession, we are also focused on how to ensure that we are providing these parents and babies with the tools that they need in order to be successful post-discharge. As a NICU team, we can create a culture of safe, functional, nurturing, developmentally appropriate care that protects and advances that rapidly growing brain. Although we have the privilege to serve this amazing patient population, we all have lives outside of this unit and things to do, whether it's planning meals for the week, coordinating how to get the kids from one activity to another, or just trying to accomplish shift tasks here while staying on top of our MyTalent learning competencies. We all have busy lives, and it's easy to shift our energy and focus into doing and not being present for our little nonverbal population. But let's take a moment to put ourselves in these babies' shoes. Let's take into account what he or she is experiencing throughout the day on a multisensory level repeatedly, not including heel sticks, eye exams, x-rays, and IV placements. It is care time. You start to hear a voice and see something approaching. You hear the click and snap as the isolate door opens, along with feeling a gust of cold air approach your skin. You begin to hear more background noise at a higher volume. You get a noxious scent of plastic gloves and a whiff of hand sanitizer. Your leg is grabbed by a cold plastic-covered hand, and a strap is firmly velcroed onto your ankle. You begin to feel a sequence of firm squeezes. Next, your arm is lifted away from your midline, your place of comfort, and a hard, cold metal rod is stuffed in your armpit fold. Then, soon after, your legs and hips are lifted up in the air, giving you this uncomfortable feeling of insecurity, not knowing where your body is in space. A cold cloth is wiping your bottom repeatedly. A thick, gooey medium replaces the wet wipe. Your hips are moved from side to side until your diaper is secure. At the same time, your stomach is grumbling. You are hungry. You are lifted up, feeling out of sorts and disoriented, then return to a soft surface. Your arms or legs and then enveloped and secured in a cloth, feeling a little more comfortable. Now, all of these cares are 100% necessary, but how we do them matters. In most NICU settings, babies only receive 5% of positive touch daily. We can change that through the way that we interact with our babies by providing those positive touch opportunities during their care time. Taking a moment to say a few words and giving them a hand hug before starting your cares can make all the difference. This is why I absolutely love to educate parents on how they can perform positive touch and two-person cares when present during these routine activities. Dad can take on providing non-nutritive sucking with a pacifier and containment to baby's extremities while providing some facilitative tucking to his or her head while mom carries out the diaper change and temperature check. Every time we touch these infants for cares, medical procedures, and with feeding, we are contributing to the growth of their neural pathways. So again, what we do matters, and how we do it matters even more. Brain pathways come from experiences, and experiences are absolutely everything. Remember the saying, what wires together, fires together. I absolutely love this image because our hands truly do impact their brains. I don't know if any of you have read this book. It's called What Happened to You. Oprah co-authored this book with Bruce Perry, who's this renowned brain development and trauma expert. I wanted to read an excerpt from this book because I thought it was so profound. If in the first 2 months of life, a child experiences high adversity with minimal relational buffering, but was put into a healthy and supportive environment thereafter, their outcome is worse than a child that experienced a nurturing and supportive upbringing the first 2 months with adversity that preceded years to follow. To me, this information is so empowering because we get the privilege to make a difference in these little ones' lives. Because for our little 32-weekers, this unit is pretty much the first 2 months of their life, and we can impact the trajectory of their future. As I had previously touched on our role as neonatal therapists, this is what we do to support that neuroprotective model. Positioning and handling. We're looking at equipment, positioning aids, positive touch, two-person care, transfers for skin to skin and breastfeeding. We're looking at environmental modifications. We know that it's important to protect our infants' sensory processing. What can we do on a macro level within our unit to ensure that those needs are being met? Feeding development, that's something we'll definitely talk about a little bit later in more detail. Neuromotor development. Every time we ask to be a part of those care times, we're looking at reflex development, tone development, movement patterns, and how they handle positioning and movement. So we're constantly assessing that even during a diaper change. Neurobehavior development. How are they doing with their overall homeostasis, maintaining homeostasis and autonomic stability when we're providing those care times? What does their motor look like? How is their overall state? Attention. Do they demonstrate self-regulatory behaviors when they're in challenging positions or when at rest? We're also addressing their musculoskeletal development. Are they able to maintain that physiological flexion when in supine to where they can be without positional support? Also, sensory stimulation. We're interpreting the quality of their sensory input and how well they're able to respond to it within their environment. We're always protecting those senses and also teaching parents how to help develop their senses as they continue to grow and develop. Pain management. I'm always telling y'all on the unit, I'm your assistant. Anytime you need help, if you're having to do a painful procedure of any kind, we're your people. We don't have to be on service to help provide that 2-person care, give the baby non-nutritive sucking or containment to their extremities or facilitative tucking to help calm them while you're having to carry out such an important medical procedure. We're there for you. And then family education is just a huge piece to our puzzle. And this is where every baby that enters the NICU setting really would benefit from our service, because a huge portion of our job is to really empower caregivers to be the best parents they can be, especially when they're performing those self-care tasks that are done every day for their babies. We also help with bonding and attachment through massage, and the way that we, teach them positive touch. We're there for psychological support and really just making sure that they are as independent as they can be within their role as the parent for when they transition and discharge home. And then hopefully you feel us really wanting to have this collaborative role within the NICU team. We really want to be a part of your team and make your lives easier and helpful. So these are the infants that benefit from neonatal therapy in a level 2 NICU. This was in a journal article that's been supported by NANT, NAN, and NPA. It lists neonates born at 32 weeks or older. So pretty much every baby within the NICU setting truly do benefit from our services. It highlights late preterm infants because we know, based on all of these studies, late preterm infants can face long-term impacts, including increased risk of developmental delays, learning disabilities, behavior problems, lower cognitive abilities, and potential health issues. Also, infants with birth injuries or anomalies, neonates that have been exposed prenatally to recreational or prescription drugs, and then also infants that are born to first-time parents, because we can truly help empower them and make them feel comfortable and independent with all of those caregiving tasks before they have to head home. I'm sure all of us are familiar with the baby tornado. This theory is what really forms the basis for individualized, developmentally supportive, family-centered care. An infant relies on all of these subsystems in order to grow and develop. The autonomic, motor, state, and attentional interactive systems are all separate but independent. The infant is continually altering his or her behaviors in response to the stimuli in an effort to establish and maintain well-regulated balance. It's really up to us as caregivers to be vigilant about observing their behaviors to help facilitate achieving that regulation. So as you can see, the core of an infant's development starts with autonomic. They have to be able to maintain that homeostasis in order to grow and develop within these other subsystems. This is especially true with feeding. That again is why what we do matters, and why we care so much about making sure that feeding is an experience that is enjoyable and pleasurable for these babies, to where when feeding is no longer reflexive and becomes a volitional task, babies want to eat. And we truly do impact that with their early experiences in the NICU because of their brain mapping. These are some preterm feeding outcomes. 99% of moderately premature infants go home on full oral feeds, but 50% of parents report poor feeding by 6 months of age. 20% of babies meet criteria for failure to thrive by 8 months of age. That's pretty significant information to absorb. was a little girl that Jennifer treated for feeding therapy once she was home. She was a preterm infant that was in the NICU for 3 months. She had a diagnosis of a omphalocele. They opted not to work on any feeding while she was in the NICU, so she had absolutely no oral work, no oral motor work, no tasting trials, absolutely nothing. She had a G-tube until she was 4 years of age. Jennifer was saying that she had, as you can see in this picture, she had to wear a glove when she played with food because she could not stand the touch of it. When you're looking at these pictures and looking at her during therapy, you can tell how not pleasurable it is for her. Because I have such a positive relationship and experience with food, I'm looking at that delicious fruit on a plate and my mouth starts to water. This sweet girl has not had that experience because of what happened to her in those early years of her development while her brain was still building those pathways. To the right, you can see that she's playing with a little baby doll. And Jennifer said that her baby doll had a little G-tube. And during her role playing, that is how she fed her baby because that's what was normalized to her. So what we do and what experiences we create in the NICU with feeding truly can have long-term implications later on in life. And it takes years to resolve. Our goal is to support skill development and parental confidence to build strong foundations for both discharge to home and for later skill development. So truly we're looking at long-term because we know what the outcomes are for feeding. The feeding experience influences parents and infants both in the NICU and after. Feeding and weight problems are some of the top readmission issues that families face. And feeding is so much more than a way to obtain growth. I know in the NICU setting, we're worried about nutrition and weight gain because that's what gets babies out. But feeding is so much more than just what we're putting in. And it's also a very emotional, psychological, and multisensory experience for both the parent and the baby. And we need to make sure that we're educating parents on how they can help. These are the oral motor opportunities that we want to make sure all of our babies get to get them ready to eat. So oral care is the first step where we're using Mom's Liquid Gold to help give them a little taste and to get them ready for eating. I love educating parents on making sure that they're doing that during each care time that they're available. Non-nutritive sucking. We're trying to give them those opportunities as often as we can. Skin to skin is paramount, right? That helps support bonding and attachment, also gets them ready for nursing in the future. A dipped pacifier with mom's milk, nuzzling, therapeutic tasting, then breastfeeding. And then bottle is last, right? Although as therapists, we're considered the bottle experts, we absolutely advocate for breastfeeding. Breastfeeding, if parents desire, which again, we never want to shame our parents into nursing, but we absolutely do want to encourage and inspire and empower them to breastfeed their babies because that only leads to positive things, bonding and attachment, weight gain, reduces length of stay. And we know that breastfeeding is a much more active feeding process than bottle feeding. So we know that they're less at risk for aspiration and other feeding difficulties that could occur with using a bottle that's more of a passive activity. So this is kind of the path that we like to take to get our babies ready for eating. These oral motor experiences and positive oral experiences help the infant transition from tube to oral feeding. It increases weight gain and it helps with behavioral organization. So this is the natural progression of feeding. First, we have to produce skill, right? Teach the skill. Then we'll start seeing some more efficiency. The endurance will come at that point, and then we can start seeing that consistency. So we always have to obtain quality versus quantity, and volume is truly a result of wanting to eat. As we are assessing and feeding our infants, as therapists, we're continuously looking at where they're at from a feeding pattern standpoint. We have obligatory, alternating, intermittent, coordinated, and integrated feeding patterns. Typically, we will not see babies at the coordinated and integrated feeding pattern. They're typically already at home when they get to meet that kind of status. Most babies will discharge home around intermittent to on the cusp of coordinated. But that obligatory pattern is where our infants are sucking, but they're not taking the time to breathe. So that's where we're having to provide that external intervention of pacing them so they can take a moment to breathe. We'll sometimes see that loss of homeostasis while they're trying to feed. And then they're certainly more at risk for having those aversive experiences when they're at that obligatory level. So that's why it's very important that we're using our observation skills to keep a close eye on how they're responding to their feeding. Alternating is where the infant is taking a little more ownership on stopping to breathe. It's not consistent, but they're making progress. And they're still possibly requiring a little bit of pacing, maybe near the middle to end of their feed when their level of alertness diminishes. So again, that's where as the feeders, we have to help make sure we're attending to those cues and stopping when we need to. And then intermittent is where they're really trying to get it together and are starting to show more coordination. This is where we're going to see more volume because, again, they're getting more efficient with how their suck, swallow, breathe pattern is going. And they're taking longer sucking bursts and appear to be breathing more often. So this is absolutely where we start seeing more volume and where they're achieving more success with their feeding. The battle of the nipples, right? Which one do we choose and why? There's so many different things that can affect flow rate. Some of those things include material, shape, size, airflow, the amount of fluid above the nipple, how tight or loose the cuff is. Remember, the slower the air exchange, the slower the flow. So the tighter the collar, the slower the flow. The thing about breastfeeding is the baby is in absolute control of how much milk is coming out, right? It's a more active process where with a bottle, we truly do rely on that flow rate. And so that's why as therapists, we take it very seriously because a bottle is absolutely more of a passive tool. And that's where infants are more at risk with having those aversive experiences and losing that autonomic instability that we want to try to avoid. Within our unit, we are truly blessed because we do have access to Dr. Brown's nipples, where at other units, they might just have the gold Similac nipple and the clear nipple, and that's all that's available. And it's unfortunate because those are one-time use, and typically they're not consistent with their flow rate. A lot of the times the nipples collapse, and it's just not a consistent way to measure how an infant is doing with their feeding. Not to mention, that's not what a family is going to be using when they get home. And I think as a therapist, my first question with any parent is, what bottle system are you planning to use at home, if any, or what do you own? And to really try to come up with a game plan based on that information versus trying to assess an infant on a nipple that's just not consistent with their flow rate. I do feel like Dr. Brown's across the board is consistent, more consistently made. And I feel like their flow rates are very helpful, especially with our preterm infants. This shows that ultra preemie nipple, the preemie flow nipple, and that level T nipple that we see. I think my only complaint is right now with the transitional nipple, it's not as easily available. So parents have to shop on Amazon to be able to get access to that nipple. So that's my only downfall that I would say with the transitional nipple. But I do truly appreciate that flow rate, because a lot of our infants, even our late preterm infants, benefit from that flow rate because it goes right in between a preemie and a level 1, which might be too much for our infants. And then here are some pictures of just a few of the specialty feeders that we have here in our unit. If we're working with a baby that has a cleft palate or possibly has moved on to AR, we'd see that blue insert for both of those kinds of bottles. And then there's the Nook, that orthodontic nipple. So the tricky part about this nipple is, first of all, it has a very high flow rate. So this is not recommended for a baby that can't manage a large amount of volume, right? So this wouldn't be great for any of our preterm infants. And then also, we always want to try to replicate the shape of a nipple. And unfortunately, this nipple doesn't exactly assimilate to many mothers' nipples. And it doesn't also help facilitate the motor movements we want to achieve or have an infant achieve to become an efficient and effective feeder. It doesn't require a lot of tongue cupping. It doesn't require a lot of tongue excursion. So this would kind of be used as a last resort for possibly an infant that has neurological deficits, but would be safe to take in a higher volume intake, or an older infant that has a very restrictive tongue tie that has yet to be treated, where this is the only way, again, that they could get the volume and intake that they need safely. This is just a great list of why different flow rates occur from the exact same nipple. These are just a few of the resources that we use to really examine flow rates. So just so you know, we absolutely take flow rates seriously because we want to make sure that our infants are getting what they need to be successful safely. I think this is such a great thing to remember. Baby plus feeder plus nipple equals flow. Because yes, we can make recommendations on a nipple and its flow rate, but how we feed our babies and making sure that we're using the accurate interventions that are recommended also impact flow rate and also impact how the baby experiences feeding. Because at this point, a culture that allows an infant to have a different experience with each new caregiver is really no longer acceptable, because the nipple should match the skills of the infant, not the preference of the feeder. Infant-driven feeding. In one of the feeding courses that I took, the presenter had stated, if the baby doesn't have a great feeding session, referring to the volume intake, it's not your fault. The baby is the boss. So if we're following feeding recommendations and interventions that we know are safe for the baby, and they are telling us they are done, that is absolutely not on us. And I think that's something important to always remember. Feeding is a bi-directional relationship, and our caregiver roles are to listen, respond, change what we do in response to the infant, and help them learn how to eat, and always make sure that it's a positive experience. Maintaining homeostasis during feeding is so important. So if we go back to that baby tornado, infant behaviors that warn of struggle typically begin with those 3 outer systems. So if while you're feeding an infant, they stop interacting, their state changes, and their movement or posture changes, those are disengagement cues, and it's time to stop. If an infant loses internal regulation, where their heart rate changes, their color changes, their respiratory rate changes, that means we missed those earlier signs that we just discussed. I feel like looking at our baby's eyes are a great indicator to know when they are finished. If their eyes are open or they have a very soft brow, that's a great sign of engagement. If they are starting to show eye fluttering, their eyes are completely closed, or we've got that tensed brow, then those are signs of disengagement. So their eyes are a great indicator to know how they're doing and progressing with their feeding. Homeostasis, that during feeding, this is what it looks like. We're seeing active rooting, sucking, swallowing without discomfort, breathing without effort, sucking with suction, limited to no spillage, and again, maintenance of internal regulation. Lack of homeostasis during feeding. If they are pushing that bottle out of their mouth with their tongue, gagging, having hard swallows, wincing, coughing, drooling, ceasing to suck, going to sleep, no effort to eat, going limp or stiff, if that tongue is planted at the roof of their mouth, that is their physical sign of saying, I am closing the floodgates. And they're probably asleep. We're always educating parents on engagement versus disengagement cues in very simple terms. This goes a little step further into letting you know what we want to avoid and when we want to stop feeding our infants. And it really specifies heart rate, color, respiratory status. Obviously, we're wanting to catch these disengagement cues when they're still at the motor arousal state changes and postural and tone state changes versus us seeing things like heart rate and color and respiratory status change. But this is a good list that I can print off and laminate for you guys to have as a reference. And then what do we do to intervene while a baby's, working through those feeding patterns? What can we do to help them? What interventions are we providing? First thing is flow rate. We want to make sure they can manage the volume intake that they're having. Pacing might be something that we have to continue to try to do. Positioning, and then providing those rest breaks when they need them. It's important that we keep a plan long enough, though, to make sure that it's working. And always remember the baby is our boss. And they're going to tell us if what we're doing is right or wrong. So here's some of the benefits to pacing. It obviously decreases the vital changes that we don't want to see. It increases efficiency of sucking at discharge. It facilitates that motor mapping and learning skills, facilitates breathing regulation. It improves endurance. So here are some of the many benefits of side lying. We're mimicking breastfeeding. We're improving respiratory support and behavioral state. We're improving the management of liquid, improving postural support, facilitating midline orientation. We're decreasing the risk of aspiration. And it's much easier to provide that external pacing if the infant needs it. These are some great feeding don'ts. Don't attempt to feed a sleeping baby. This includes the signs of REM sleep. This is when they're most at risk for aspiration. So we absolutely do not want to feed them while they're sleeping. We do not want to choose an inappropriate type of nipple and attempt to help them take more volume. We don't want to manipulate the bottle via tapping, twisting, pumping, or jiggling. I love this. If a breast doesn't do it, neither should the bottle. When we're doing things like that, really the only reason behind doing that would be to try to get more volume into the baby. And, you know, we've selected as a team, right, a nipple and a flow rate that is exactly what the baby needs to consume the volume safely. So manipulating that there's really no benefit. Plus, we want to make sure that that baby across the board is getting the same sensory experience when they're eating. So we really should just serve as the vessel, this stagnant vessel, right, for that baby. And the infant should be the one who's actively consuming and taking the milk through their oral motor skills. We might have to externally pace to get them to actively breathe, right? But we don't need to be changing the position of the nipple and twisting it to try to get more volume in. That's a big no. And then do not continue to oral feed when an infant shows signs or symptoms of distress. We know what those disengagement cues look like. Don't force an infant to finish a bottle, right? If they say they're done, they're done. It's totally fine to gavage. Again, if it's a pleasurable experience, they're going to want more. And so we need to make sure that every experience that they have counts. And we don't need to feed a baby in a bed or warmer unless medically appropriate, because we need to make sure that their experience feels natural. Holding a baby in a crib while we're leaning over it is just not the same experience as being held and comforted, which is what they're going to have once they get home. And then switching the nipple too often can lead to decreased feeding progression, regression, oral feeding skills, and delay the time it takes to full feed. So that's why we really should be trialing the same nipple for at least 24 to 48 hours prior to switching, unless there's a significant safety concern. And obviously that's when it needs to be addressed. And then if a feeding specialist is following, so if Jennifer and I are following, it'd be great if we could just talk about it, because we truly care about your input. You're with that baby for a whole 12-hour shift. I mean, that is a long time to be with a baby. You guys are truly seeing what a baby's doing throughout an entire day's time. And so your input is extremely important and paramount for us to understand how they're doing and to see if we need to change the flow rate. But anything we try, we need to at least do for at least 24 to 48 hours. And then let's talk about it. Caregiver education is so crucial. We want to make sure that we're educating parents on feeding development, engagement cues versus disengagement cues, oral motor readiness tasks so they feel empowered to do those things every time they hit the bedside. Promoting skin to skin and breastfeeding, quality versus quantity. So changing our spiel when we talk to those parents that call or come into the bedside. Instead of saying baby Sally only took 15 mLs last feed and 23 the time before, we could say something like, you know what? I was so proud of Sally. She was wide awake after her cares. She was so eager to eat at the beginning of her feed. She did require some pacing to support her to make sure she took some time to breathe. But after she started getting the hang of it, she was even taking her own time to take a breath on her own without me having to pace. I was so impressed at how long she stayed alert before we had to discontinue her feed because she got a little tired. She has made such great progress. Those kind of comments make such a difference for parents. They are hearing success instead of fail, right? Because they know that that baby has to take 100% of volume recommended for 48 hours before they're able to go home. So instead of them feeling like fail, let's talk about the quality and the coordination piece of it to where they are getting set up for success long term. As we've discussed, what we do matters, but also documenting does as well. Anytime I come on a shift, the first thing I do is look at the feeding flow sheet, because what you guys have documented is just the most important thing for me to kind of get a good snapshot or overall picture of how this baby's doing, based on what recommendations we made. The nipple type, how long it's taking for the baby to eat, what was their feeding readiness score? Did it remain the same throughout the feed? If I'm noticing things like choking and coughing, was it discontinued? Was feeding discontinued right after the choking or coughing? Was a rest break provided? All of those little specific details make a huge difference for me to know how this baby is doing and if they're successful with what recommendations are being made. So anyways, all that information and what details you can provide really makes a huge difference, because I really rely on y'all's expertise and what you're observing in order to continue to make recommendations. And then if you're ever noticing a baby that you have that isn't on OT/ST service, but is showing some of those disengagement cues and isn't doing well with what nipple is provided, please let the nurse practitioner know, and Jennifer and I know, to where we can make sure that baby gets on therapy services, or at least gets evaluated or screened to see if there's anything we can do to help. And then if for some reason that feeding flow sheet doesn't give you enough options to write a more detailed response to how that baby's doing, and you are concerned about safety, feel free to put that in the notes section under the care plan to where it's visible that there are areas of concern that need to be addressed, so we can, make sure we're tracking that and doing the best thing that we can to make sure that baby's feeding successful. Well, this is the conclusion of our presentation. I know Jennifer and I truly love our time spent in this unit. You all have just been so amazing, and there have been so many times I have just been in such awe of your skilled expertise when managing this such special patient population. And I know we feel absolutely blessed to be a part of it. So thank you so much for your time.